The Sepsis 2026 has done something guideline panels almost never do. It made de-escalation a strong recommendation and then told you the evidence behind it is very low certainty. But read the small print. That upgrade only applies where you have a confirmed organism and susceptibilities, which is according to statement 36. Culture negative, which is statement 37, and it stays conditional. This is the finale, episode 505 of Sepsis 2026 guidelines, de-escalation and antimicrobial stewardship. What SSC 2026 actually changed and what it deliberately refused to commit to, and the examples most candidates walk straight past. Let's dig in with our MedEd quartet, Techie, Brady, AU, and AG. So, welcome to the finale, episode 5 of 5, and the capstone of the series. This is the stewardship half of the infection domain, where everything we've built actually comes together. Here is the shape of it. Part 1 of this video is the big upgrade, which means de-escalation. Now it's a strong recommendation. Plus what SSC 2026 says about the blood purification and about source control and its timing. Part 2 of the video turns practical, which means procalcitonin, how to actually use it, how long to treat, and where those duration numbers actually come from. So we need to look at the evidence. And choosing your antimicrobials according to the empirical spectrum by risk. And the examples which a lot of examiners reward. If the rest of this series has been about acting decisively, which means recognize, resuscitate, and get antibiotics in ASAP, this episode is the opposite discipline, which means knowing when to hold back, when to narrow them down, and when to stop the antibiotics. That's our Brady, our turtle. This is Brady's episode. A deliberate pause here because this is the ethical core of the whole episode. De-escalation isn't only a clinical recommendation. Every unnecessary day of antibiotics is an act of harm for the patients and for the healthcare system, and it lands in 3 places at once. On this patient, the first one, Clostridioides difficile, whose risk climbs with every extra day and every step up in the spectrum. Piptazo, clindamycin, and the fluoroquinolones are the worst offenders, alongside colonization with resistant organisms and plain drug toxicity. On the next patient that you see in that bed, your prescribing today shapes the ward's resistance ecology, and C. diff spores persist on surfaces for months, waiting for whoever comes next. And then on the whole system, whether it's NHS in the UK, you're talking about American healthcare system, in Middle East or any country, there is the Graham study attributed nearly 1.27 million deaths directly to bacterial resistance in 2019. You're talking about 7 years ago. And nearly 5 million once you count the associated deaths, which makes it a bigger killer than HIV or malaria, and the pipeline of new antibiotics is really thin. So de-escalation is never just tidying a drug chart. Done properly, it protects all 3 at once. And that is why SSC 2026 treats it as an obligation, not an option. Now to the bedside, looking at the de-escalation pipeline, which has 3 steps: culture, identify, and narrow. And in 2026, each one finally has an attached statement number. Statement 36 is the upgraded statement, which says once you have a confirmed microbiological diagnosis and a susceptibility profile in front of you, narrow the spectrum or stop the agent that you no longer need. That's the strong recommendation. But notice the condition built into it. It needs that the confirmed organism and those susceptibilities should be available. Where cultures come back negative, then you are talking about statement 37, which says, that it's conditional. So let's look at the 3 steps. Step number 1, culture first, which is statement number 7. Strong and retain. Strong evidence and retain. This means collect blood cultures as soon as possible and ideally before the first dose. Now be careful here because this is where candidates drop marks easily. SSC 2026 does not specify the number of blood culture sets and also doesn't mandate aerobic and anaerobic bottles, and also there is no 45-minute rule anywhere in the guideline. I've covered this in detail in episode 3 on antibiotics, especially the beta-lactams. Now, the two sets of blood cultures is a good microbiological practice, and also it's exercised and practiced in most units across the world, especially in the developed countries, like in NHS hospitals in the UK, Middle East hospitals here in Qatar, and also in the US and a lot of Western European hospitals. So please follow your local policy. But this is not SSC 2026 guideline as such. This does not mean that you don't have to follow this based on your institution policy. Please do that. Now, the deeper point here is that without cultures, de-escalation cannot happen. So that's what the whole pipeline runs on. Coming to step number 2, identify and review. Once you've done the cultures, please review the results every day. It takes at least 24 to 48 hours initially for the broad group of pathogens to be identified. For example, gram-negative bacilli in the blood culture, or gram-positive cocci. It doesn't give you isolate. So isolate will take another maybe 24 hours or 48 hours. Usually day 2 or day 3, you may be able to get the isolate. And then between day 3 and day 5, you may be able to get the final susceptibilities for that isolate. So again, unless and until you actively review the results every day, you may miss the blood cultures or any fluid cultures for that matter altogether. That's the important part. Especially when it's a busy ward, you're doing ward rounds every day, you're seeing new patients, it may be easily missed. So that's the key thing. And in case a non-infectious etiology is identified, then there is a strong, expectation to stop empirical antimicrobials altogether, because there is no added benefit, no benefit actually of antimicrobials when there is a clear non-infectious etiology. And also, you have to ask yourself, can I switch from IV to oral antimicrobials? That's another important point. Finally, step number 3, narrow and document. Once you have cultured, you've identified, now you can easily narrow down the spectrum and document it clearly. This is statement 36, which is now strong. Now read the remark carefully because it's broader than people assume. De-escalation means discontinuing unnecessary therapy or narrowing the spectrum, both of them. So stopping a redundant second antimicrobial when it's not needed is as good, as important as narrowing down a single agent from broad to narrow spectrum antibiotic. For example, piptazo becoming flucloxacillin or cefazolin once you have MSSA identified. Meropenem stepping down to coamoxiclav once you have an ESBL negative E. coli. And again, piptazo becoming benzyl penicillin for a pneumococcal infection. Now, a caveat to the documentation prompt. Writing the decision in the notes is an excellent gold standard stewardship. And it's how antibiotic times out, the timeouts usually gets audited. But the SSC 2026 does not require it. But please follow your local policies. Again, I keep saying, if not documented, it's not done. So gold standard to document it clearly. And clinical pearl, de-escalation is not the same as stopping. Narrowing is statement 36 of the guideline, but stopping because the cause turned out to be non-infectious etiology is statement 35. Let's look at the de-escalation evidence and what the trials show. De-escalation is a strong recommendation resting on very low certainty evidence. So that's the key point here. Now, picture our AG, Argentum, the balancing dove. A strong recommendation normally needs at least moderate certainty data, and the panel didn't have it. So they went strong anyway because the balance of effect is so lopsided. De-escalation is safe, it costs nothing, and it cuts resistance, toxicity, and drug interactions all at once. Please review our previous slide, one of the previous slides that we discussed. When the benefits are so much one-sided, the strength of the recommendation can outrun the strength of the data. It's like a paradox. That is a single most examinable idea on this particular slide. Now, if you look at the column 1, it's the guidelines on synthesis. 26 studies, only 2 of them were randomized. And the short-term mortality risk ratio was 0.77, ranging between 0.64 to 0.92. And the resistance risk ratio was 0.71. Now, both point towards the right way, the correct way, both with very low certainty, because 24 of these 26 observations, the studies were actually observational, hence the weaker evidence. And the panel flags that catch very honestly, confounding by indication. Now, in observational data, de-escalation tends to happen to the patients who are already improving. So some of the apparent benefit is the recovery driving the de-escalation, not the other way around. So that's why it's a paradox. Column 2 in the middle is a number that changes the conversation. A target trial emulation in JAMA Internal Medicine, uh, which covers almost 37,000 adult patients in community onset sepsis across 67 hospitals. Day 4 de-escalation of anti-MRSA or anti-pseudomonal cover versus continuing it. 90-day mortality with odds ratios of 1.00 and 0.98, completely flat. Fewer antibiotic days, shorter stays. And here is a stewardship story hiding in the data. A more than twofold variation between hospitals and how often they de-escalate. This barrier isn't evidence, it's a behavior. Column 3 is a balance. That's what I was discussing about our Argentum Dove. New England Journal of Medicine 2025, one of the top journals. 3,608 patients across 74 hospitals in 7 countries, over half in intensive care. 7 days of antibiotic versus 14 for bloodstream infection. And then they looked at the 90-day mortality, which was 14.5% against 16.1%, non-inferior. But there were exclusions because that's exactly where the 7 days stops. Staph aureus bacteremia, prosthetic infections, and undrained abscesses were all excluded. And that's why it's a caveat, because the Staph aureus in the bloodstream actually needs at least 14 days of antimicrobial therapy. So let's look at the procalcitonin, the biology and kinetics, and how to use it. Now, it's worth understanding it properly because it's one of the most misused tests in sepsis. Briefly, it's a calcitonin precursor that the parenchymal organisms release systemically in response to bacterial endotoxins and the cytokines. Now, viruses don't drive the same response, which means that it makes it a very useful marker of differentiating between a bacterial and a viral infection. The kinetics give you the one number examiners want. Procalcitonin rises 2 to 4 hours after a bacterial stimulus and peaks at 12 to 24 hours and not 24 to 48. Then it falls with effective treatment. So a failure to fall means either inadequate therapy or a source that you haven't controlled. Now, from examinable core or clinical examination point of view, in your MRCP or USMLE exams, this is an asymmetry. Why? Because to start antibiotics, the statement 22 says clinical evaluation alone. Because if you're suspecting sepsis, you don't need further evidence. You don't need culture. Same as procalcitonin. It earns no place in the decision to start antimicrobials. However, to stop, the statement 40 says procalcitonin and clinical evaluation together. So this is conditional and low certainty carried over from the sepsis 2021 guidelines. So start on clinical grounds, let procalcitonin help you to stop them. And I will say it very plainly, SSC 2026 gives no procalcitonin thresholds at all. The cutoffs on the screen, the 0.5 micrograms per liter or 80% fall rule and the 0.25 figure are all trial stopping algorithms, not the guideline numbers. That is really, really crucial. And the honest modern trial is ADAPT-Sepsis with 2,760 patients across 41 UK intensive care units. It included procalcitonin guided course shortened antibiotics, and they noticed the results at 0.88 days earlier, which is almost 1 day, and met the non-inferiority for mortality, while the CRP arm, which was the other arm, failed on both counts. Again, some real benefits, but modest results. And the rule that matters most at the bedside, Procal is falsely high in some conditions like trauma, surgery, and pancreatitis, pretty much, similar to the conditions which cause the SIRS, systemic inflammatory response syndrome. And also, it's low in localized infections because there is no systemic response. And all one of the practical aspects is that it is simply unavailable in much of the world, much of the developing world. So it never rules sepsis out, but you never delay antibiotics waiting for it. Now, this is a busy slide, antibiotic duration. Please remember that Surviving Sepsis Campaign 2026 does not give any source specific durations at all. The statement 39 of the guideline is a single carryover, which is a condition statement on very low certainty, and it says only one thing: shorter over longer duration, where source control is adequate. There is no table of durations in the guideline and no grade attached to any individual infection. Every number on the screen that you see is real and worth memorizing, but it just comes from different trials and different guidelines, disease specific international guidelines, not from SSC 2026. Now this is the key important thing. Remembering them helps you in your exams, but attributing them to SSC 2026 is the trap. You need to be very careful. Now, the one number that's generally guideline adjacent in SSC 2026 is the one that we touched on upon in a few slides ago, is the 7 days for bloodstream infections, because the balance trial cited is in the SSC text and it supports shorter courses. We have already discussed about the 7 days versus 14 days, but the exclusion criteria including Staph aureus bacteremia, prostatic infections, undrained abscesses, and Staph aureus in the blood is a minimum of 14 days because of the endovascular seeding. The other one is the intra-abdominal sources of infection. So stop it. The trial showed 4 days after adequate source control is achieved. So 4 days should be enough. But the corollary matters more than the number, because if the source isn't controlled, no duration is correct, because antibiotics do not substitute for the drainage of the collection or abscess, because there is very poor penetration of drugs or antibiotics in the abscess cavity itself, and hence you cannot achieve the correct MIC, minimum inhibitory concentration of the drug. Now, everything else on the table, if I just want to go through one by one, for example, 5 to 7 days for community-acquired pneumonia, 5 days if improving by day 3, etc., etc. It's IDSA and ATS and also BTS, American, British, and International Society of the Infectious Diseases Society of America, all of them, and the different guidelines based on these organizations. Hospital-acquired pneumonia, 7 to 8 days, dependent upon the non-fermenter organisms. They may require longer, for example, Pseudomonas and Acinetobacter. Again, it's more of a society-specific guideline rather than SSC. Urinary tract infection, urosepsis, uncomplicated, 5 to 7 days. But if it's a complicated urosepsis due to obstructive uropathy, renal abscesses, then duration definitely is going to be longer. Again, depends upon the local policies and guidelines. Two conditions worth mentioning: bacterial meningitis and infective endocarditis. Both of them are not sepsis per se. So remember that, please. Once again, follow your local policies and guidelines based on the duration, antimicrobial sources, cultures, etc. So this table, again, a disclaimer, it's an educational guideline. It's not a replacement of your local policies, practices. Please follow your institutional, regional, local, national policies, whichever the case may be. It's only for education guide. It's not a replacement of what you have to do in your clinical practice. This is one of my very favorite and practical slides, actually. So, empirical antibiotic spectrum by risk factors. So, 4 new statements. Now, this replaces the old combination therapy teaching, because SSC 2026 has no combination therapy statement at all. In its place, 4 new statements that change how you choose antimicrobial cover by risk factor for the patient, not by reflex. Now, this is AG, our Argentum Doves slide, because each of the 4 is a weight up call, like a balance of probabilities, not a default. MDR cover first, multi-drug resistance. Statement 25 and 26 cover it. Risk factors for a specific resistant pathogen, then you need to cover it irrespective of the overall situation. When there is no risk factor, then the suggestion is against covering for the MDR. Now, the word that matters here is specific, which means which organism and why, not whether the patient looks resistant. So this is the important. You have to think about the pathogen, not the patient. Obviously, the patient with the pathogen, but this is a specific recommendation. The risk factors are visible on the screen, as you can see. Previous colonization, previous infection, previous or ongoing colonization, previous infection, recent broad spectrum antibiotic use, or a high prevalence unit where you suspect that MDR might be there. And the restraint is evidence-based, like why to avoid giving the MDR coverage because the odds ratio favor the MDR cover. The resist, you know, the odds ratio is 0.71. But this comes entirely from observational studies for MRSA data, and there is no benefit for Acinetobacter, ESBL producers, or the carbapenem-resistant Enterobacteriaceae. Now, the second half is anaerobic cover. Statement 28 and 29 of the guidelines covers it, and this is the more surprising pair actually. No specific risk factor for anaerobic coverage. You do not need to cover with antimicrobials for anaerobic cover. For example, lung and urinary sources, uh, they won't benefit. And even unnecessary anti-anaerobic therapy may actually raise the patient's mortality. And anaerobic, because anaerobic gut flora is healthy gut flora, the normal one, which actually does protective functions for the body and the body's immune system. Now, you only add it as according to the statement 29 when you have high risk of high degree of sources, for example, deep-seated or intra-abdominal infections, also deep-seated pelvic infections like gynecological or obstetric infections, necrotizing soft tissue infections, gas gangrene, gas-forming organisms, head and neck and CNS abscesses. So these are the specific sources. Now, one carve out, if you need MDR coverage and you also have piperacillin or carbapenem as one of the antimicrobials, then they do have decent anaerobic coverage as well. So incidentally, that should also cover for some anaerobic coverage. The whole slide actually reduces down to two questions before the first dose of antimicrobial is considered. Number one, does this patient have a specific risk factor for MDR pathogen? And does this source carry anaerobic risk? Answer these two, and the spectrum of antimicrobial choice will become relatively easier to identify. From the exam point of view, anaerobic cover is decided by the anatomical source, not given routinely as per statement 29. So let's look at the selective digestive decontamination and some other relevant guidelines statements. So there were three more statements. The first is the one to walk out remembering because it's the highest certainty new recommendation in the entire infection domain and it's quite counterintuitive. Statement 41 is about the selective digestive decontamination, which is SDD, which means the use of non-absorbable topical antimicrobials like polymyxin, tobramycin, amphotericin B, etc. to oropharynx and upper GI tract, plus a short broad-spectrum IV antibiotic course in ventilated patients. It spares the anaerobes. It's conditional but with moderate certainty. Nothing else new here is graded that highly. Suggested in mechanically ventilated patients only with sepsis or septic shock and units where antimicrobial resistance is low. I have covered it in more detail in sepsis episode 3, antibiotics. The mechanism is, as you know, it's already discussed in the previous video, but because of the local effect, they can minimize the gut flora, the the microbial overload, the bacterial overload, and hence improvement in outcomes. This is the rationale. Now, what matters here is the evidence because it overturns the old objection. Everyone assumed that selective digestive decontamination would breed resistance. This is a natural, concern. But the meta-analysis of 32 trials, including over 24,000 patients, found the exact opposite. The resistance risk was low at 0.64 and it went down, and the mortality risk ratio was 0.91, so significant. But the caveat is that the whole story for us, that balance holds in low resistance units. That is a critical point. In high resistance settings, it may not be applicable because the trials are not there. So it's an intensive care unit by unit decision, depending upon which part of the world you're practicing and how the local antimicrobial flora, local and resistance, the microbial resistance flora is. For a region like Gulf or GCC or South Asian audience, it depends upon the local profiles and the policies. Again, follow your institutional policy as appropriate. Coming to statement 31, which is pathogen specific rapid diagnostics. conditional with low certainty. And then here is the honest finding, which also is this episode's entire thesis in one line. The tests alone didn't change the mortality. The risk ratio was 1.03. What actually changed was the outcomes, was rapid diagnostics coupled to a working stewardship program. The test creates the opportunity to de-escalate. Only the stewardship response turns it into patient benefit. So it's not just a test, it's how you apply it. The third block is where the guideline honestly says it doesn't know. And this is worth learning as an intellectual integrity, to be honest. On Candida biomarkers, the statement 32 and 38 both suggest against. Don't use them to start empirical antifungals and don't use them to stop either. Which with statement 27's suggestion against routine empirical antifungals gives you a clean antifungal stewardship position. How many times of the units we find out Candida fungal result in urine or some other sample, but the ID colleagues and microbiology colleagues say, do not even consider it because the patient looks clinically stable. So surveillance cultures under statement 30 and drug monitoring under 34 both sit on case-by-case footing. So this is the key and important point. For details of the trials and studies, you can always pause the slide and have a look at it in more detail if you want to. For blood purification, the guidelines, what do they say? The first job is to get it right in the first place because most people may get it confused. What changed between 2021 and 2026 is the scope, not the strength. In 2021, there was a single statement about of use against polymyxin B hemoperfusion. In 2026 guidelines, the statement 83 specifically suggests against blood purification as a whole class, which includes hemoperfusion, high dose hemofiltration, and plasma exchange all together, all of them together. And the statement 84 keeps polymyxin B as its own separate statement. Now, both are conditional, suggest against, inverted commas. Neither is strong, and statement 83 actually carries a certainty downgrade relative to 2021. The trials with the citations, that matter, you can search them up or look at the on-screen details. Euphrates in JAMA 2018, 450 patients in multiple organ dysfunction group, 28-day mortality was 44.5% versus 43.9%. Risk ratio was 1.01 with a p-value of 0.92. Again, flat result. Other trial is Abdomix, 243 patients with peritonitis induced shock. Day 28 mortality was 27.7% with hemoperfusion versus 19.5% with standard care. That's a non-significant increase with an odds ratio of 1.59. A stronger basis for recommending against than mere no benefit, and it's why the panel was comfortable in doing so. Polymyxin B hasn't vanished though, and Tigris in 2025 is the reason why, because the benefit signal in the narrower endotoxin activity of 0.60 to 0.89 subgroup analysis. So the device question isn't closed, but the guideline just reflects where the evidence sits today. Now, this is one condition where the candidates may get confused in exams, and I will say it out very loudly. Now, the standard dose continuous renal replacement therapy or continuous veno-venous hemofiltration, so CRRT or CVVH for acute kidney injury, AKI, is completely unaffected with this guideline. Please remember, that is governed by the renal replacement statements. This statement 83 that we are talking about is about using blood purification methods to treat the sepsis itself. The AKI treatment and the requirement is still stands there, but the sepsis meaning clearing endotoxins, removing the inflammatory cytokines. It's not about managing the kidneys. So that is a crucial differentiation between the two. Now, source control, statement 23 and 24 and the 6-hour target. This is one of my most favorite slides. Why source control? If the last few slides were regarding our Brady, telling you to slow down, narrow it down, take your time, this one actually is techie, which is speed. Some things in sepsis you do fast, and finding and drilling the source of infection is top of that list altogether. Now, let's clear it out. Some people say that SSC gives no window, but it does. Statement 24 suggests early over late source control and ideally within 6 hours of diagnosis, conditional with very low certainty. And statement 23 comes before that, um, and it's a good practice statement. Rapidly evaluate every patient for a specific anatomical source that needs emergent control. Now, where does a 6 hours window come from? It's from observation studies the panel reviewed most often define early that way, so they adopted it while saying earlier is better where feasible. Now, source control is a broad term. So, what does it include? Three main things: drain the infected collection, remove the infected device, or cut out the infected tissue. For example, let's come to the first one: an abscess, empyema, a septic joint we discussed previously and also in the antibiotic section of episode 3. The antibiotics do not penetrate that fluid that well. It's like a poor penetration, and that's why the MIC, minimum inhibitory concentration required for therapeutic purposes, is very low. And it's highly unlikely for the antibiotic to achieve that. That's why the drainage is the primary treatment. When I was doing my house job in general surgery, I remember our professor used to say that if there is abscess, it has to come out. It has to be drained. Simple. Period. Full stop. So that is a key thing. The second example for the removal of the infected device is epilepsy, central line associated bloodstream infection. How many times we have seen nephrology patients with perm cath related sepsis and infections and recurrent infections, and the ID colleagues, infectious diseases, microbiology colleagues, they recommend line removal. But then there's a discussion between nephrology and vascular surgery about how difficult that access is, and it's almost impossible to remove it. So without removal of the source itself, the antimicrobials have a very little role, if any, in achieving the desired result. So if there's a source, just remove it. That's the key thing. However, overall, it's a balance between having a secure access for dialysis versus not. Again, it depends upon the multidisciplinary team input. The third example is the necrotizing fasciitis, cutting out the dead tissue. Surgical debridement urgently with in a condition where you have the disproportionate degree of pain out of the skin changes, that's a clinical cue. Now, the two timing caveats, the slide lists are good teaching point, but are not SSC numbers, please remember. And I will say it out very loudly. Number one, necrotizing fasciitis has no separate window in the guideline. And number two, the cholangitis timing belongs to the Tokyo guidelines, not SSC. So again, these are good learning points, not specific to SSC 2026. And the single most useful line for a ward, clinical ward, internal medicine, acute medicine, AMAU, acute medical unit audience is the guidelines on. And this is where the techie's whole message lies in one sentence, which is that prolonged attempts at medical stabilization without source control in a severely ill patient is unlikely to succeed. This is the answer to, inverted commas, the patient is too unstable for theater. How many times we hear it on the wards? How many times we hear it from our surgical colleagues? From clinical exam, MRCP, USMLE point of view, failure of source control is the commonest cause of apparent antibiotic failure in sepsis. If someone isn't improving on appropriate antibiotics, the question isn't which antimicrobial is better or broader or more powerful. The answer is where is the undrained source? Again, clinical practice, local policies, MDT care. That's all that I can say. The day 3 stewardship checklist based on surviving sepsis 2026. Another deliberate stop. This is the Brady's discipline that we discussed earlier, turn into a routine. So the 6 question to run on every sepsis patient before you touch the drug chart. Step number 1. Are cultures back? Statement 7, got them taken. This is where they earn their keep, and you have to ask this question virtually on a daily basis. Step number 2, can I narrow down the antimicrobials based on statement 36? If you have a confirmed organisms and susceptibilities, strong evidence. If you're not suspecting infection, statement 37, then it's, if cultures are negative based on statement 37, then it's a conditional recommendation. Step number 3, can I narrow by risk depending upon the patient's clinical presentation? The new 2026 material, statement 25 and 26 for MDR and 28 and 29 for anaerobic cover, we have already discussed based on the specific risk factors. Step number 4, can I switch IV to oral? Not an SSC statement as such, but strong general evidence. If the gut works and there is an adequate oral agent available, suitable, then you can switch it. Step number 5, is the source controlled? Statements 23 and 24. And if not, imaging and a surgical opinion, ideally within 6 hours. And nowadays, intervention radiology teams, IR colleagues are doing a fantastic job in trying to address the source control if appropriate. And lastly, statement number 6 or step number 6 is, what is the duration target? Again, looking at the statement 39, shorter is sweeter and better than longer. So set a stop date today rather than leaving it indefinitely. This is the grand finale summary slide of all the 5 episodes in one snapshot. So I'll keep it simple. Each episode is referred in, and with each recommendation guideline, you can refer to those episode videos for more detail. First of all, the deprecated and downgraded, the left column. Q so far as a screening tool is out. News 2, Muse, and others are preferred. Episode 1. Normal saline as a default crystalloid because of the risk of hyperchloremic metabolic acidosis is not recommended at all. Episode 2. Protein supplemental albumin is not considered, unlike 2021 guidelines, and because crystalloid use is much preferred over albumin. However, if there is a large volume resuscitation done with crystalloids, then you may consider albumin, but the large volume has not been identified in SSC 2026. It's individual choice. Next, number 4 is angiotensin 2 as a guideline rescue is totally out. Episode 4. It's not used as a first line at all. It's a second or third line, but not as a separate indication. It's an add-on. Episode number 4, please, for vasopressors. Then episode 4 also covers the use of beta blockers for the shock state. So beta blockers are not considered in the septic shock on its own. However, if there is a specific indication like controlling atrial fibrillation, fast atrial fibrillation, etc., then you may consider it. But that's again not sepsis related. It's for rate control. And finally, in episode 5, we have discussed about the blood purification to treat sepsis is totally not recommended at all. Let's look at what has been retained in this guideline. First one, norepinephrine as first line and vasopressor, episode number 4. Strong evidence carried over, not downgraded. MAP target of 65, avoid overshoot, and revised MAP of 60 to 65 in people above 65 years of age. So for elderly, conservative target. Episode 4 again, vasopressors. Then third point is 30 ml per kilogram of crystalloids in the first 3 hours. Episode 2, fluid resuscitation, please. Then blood cultures before antimicrobials. Episode 3, strong evidence, but no blood culture count has been recommended, like 1 set or 2 sets, and also no 45-minute rule in the guideline. And then episode 5, just this episode, we covered about early source control, really important, especially within first 6 hours. And the sepsis 3 definitions in episode 1, it's unchanged. Sepsis is still a clinical diagnosis, not a single test at all. What has been upgraded or new? Number 1, News and News 2 are in, and Q so far is out. It's upgraded. Episode 1 covers that. Number 2 is the prolonged beta-lactam infusion. It's a new upgraded evidence. In episode 3 covered it, statement 33, moderate certainty evidence. Then de-escalation is upgraded according to statement 36. It's covered in episode 3, and it's strong on but with a low certainty evidence. MAP of 60 to 65 for elderly above 65 years of age. It's a new evidence. I did touch it in the retained section, but that was in context with the conservative, MAP rather than overshooting. So basically, it's a new guideline, not a retained one. So this is the new policy: 60 to 65 millimeters of mercury in elderly population. And episode 4, vasopressors, covers it. And in episode 5, we just touched upon the selective digestive decontamination in low resistance units is new, but elsewhere it's not recommended. Active fluid removal, we covered in episode 2, fluid resuscitation. It's a new recommendation, new guideline as per statement 89. And de-resuscitation after the acute phase, which is totally new, which means fluid removal can be equally beneficial in patients in whom you have overdone the fluid resuscitation.